Each time we use those technologies, you worry that we'll do something that will ruin the webinar, but hopefully it will be all okay. That's great. So we are on YouTube also. Each time we use those technologies, you worry that we'll do something that will ruin the webinar, but hopefully it will be all okay. Now what I need to do is close this. Hi. There. I'm just checking if YouTube Live is working. That's good. So a couple of minutes and we'll go. Omar, are you okay?
Yes.
That's great. Yeah, I think YouTube Live is working fine. So we can close that, close this. Oh, Andreas is here. Andreas, how are you? You might end up getting Andreas also joining us. I'll share my screen. Desktop. That's great. I think we already have 300, 400 people online. All right. So we're just going to start. Good evening, everybody, and welcome again to another webinar with the iBreast book. This is the 7th webinar, and we have a great panelists and speakers today. We have Kate Williams from the Pennine Acute Hospitals that will talk about the future-proofing in unprecedented times, total magnetic conversion. We have Peter Barry from the Royal Marsden, who's going to talk about the targeted axillary dissection, the magnetic node marketing at the Marsden. And we have Jill Dietz, who's going to talk about more than just seed localization, the USA experience. So this is one of the webinars about de-escalation of surgery, and we're mainly concentrating on the axilla. I have with me also my colleagues, Ash Kotari from Guy's Hospital and Omar from Cairo in Egypt, who have been always with me in most of those webinars. We feel like the Three Musketeers now online for the past few months. Omar will introduce the first speaker.
Yes, absolutely. Thank you so much, Yazdan. And we will be, I'm honored to present our dear colleague and friend, Professor Kate Williams from the Pennine Acute Hospital NSS Trust to speak about total magnetic conversion, future-proofing in unprecedented times. You have the coming 20 minutes. Thank you.
Thank you, Omar. That was a very nice introduction, but I'm certainly no professor. So today's talk from us is, well, my angle is basically how we converted to a totally magnetic system to help us during this kind of COVID-19 crisis and what that meant for us in our service. So I'm just going to try and start a pre-recorded video, so just bear with me. Good afternoon, everyone, and many thanks to Yazdan for asking me to talk today. Today's webinar is obviously about addressing the management of the axilla in breast cancer treatment. And my particular presentation is there to give you a flavour of how converting to a totally magnetic localization system for both breast lesions and the axilla has helped our unit to continue to offer safe and effective breast cancer surgery during the challenges of the COVID crisis. As a form of an introduction, I thought it best to tell you a little bit about our breast cancer unit in North Manchester. We are a large symptomatic breast service located in the northeast sector of Greater Manchester. We run clinics in both the Royal Oldham Hospital and North Manchester Hospital. We actually perform all of our surgical procedures over the North Manchester site. And interestingly, North Manchester is also the regional centre for infectious diseases, which obviously during the recent pandemic has become incredibly relevant to us and our service. We see around 8,500 patients in the one-stop service per year and treat around 400 cancers per annum. As we are a symptomatic service, most of our patients have palpable breast cancers when they are seen at presentation. So traditionally, actually, localisation of impalpable tumours wasn't really something we had to consider very often. But as the use of systemic therapies as neoadjuvant treatment to try and downstage tumours to allow breast-conserving surgery in the majority of patients has taken over the last few years, the number of impalpable lesions we're having to operate on has increased. So for those that don't know, when I talk about lesion localization in the breast for impalpable tumours, that's there basically to allow surgeons to remove the tumour with a sufficient margin around to allow safe excision. Traditionally, that's done using the current standard of care using a hook wire. So the radiologist puts the hook wire, or radiology team put the hook wire into the breast, which guides the surgeon on the time of surgery down to the tumour by following that wire. Re-excision rates using this method are around 20 to 25%, and there's many different reasons for this, but one of those main reasons is the fact that the wire can actually move once it's been placed in the breast, and that causes patients to have to undergo a second operation to ensure adequate excision. Sentinel lymph node biopsy is a technique that's been around since the 1990s. That involves marking and locating the first draining lymph nodes for excision biopsy so they can be sent off for histological assessment and the disease can be staged. The current standard of care for this is to use a dual technique involving the injection of a radioisotope within 24 hours of the surgical date. And that's because there's only a 6-hour half-life with the radioisotope. The radioisotope is usually given in a nuclear medicine department by their team, and it requires specialist licensing for administration, as well as specialist knowledge of waste disposal in theatre, as well as the handling of the specimens as well. Alongside the isotope, patent blue dye is used and is injected at the time of surgery on the operating table. In North Manchester, we've actually been early adopters of the MagSeed system for impalpable tumour localisation, and we've been using this system since April 2018. Our main driver to switch to this system was the fact that our breast radiology department is actually within a standalone building, and that's some distance away from the breast theatres. Before the adoption of this MagSeed system, our theatre scheduling meant that we had to depend on patients not being listed first on a list if they required a wire insertion. And that's because of the time spent transferring patients from one department to another on the day of surgery, but also the time it took to actually place the wires accurately on the day of surgery and to perform the check mammograms as well. This was particularly challenging in patients with poor mobility, particularly as hospital porters were not ensured to take those patients across the car park in a wheelchair. So we had to actually rely on hospital ambulance transport to ensure that those patients got from one department to another. And that often caused delays and poor theatre efficiency. And also patients found the whole situation, the whole process quite stressful. The MagSeed system allows us to uncouple tumour localisation from the day of surgery, which increases theatre efficiency and also allows more flexible radiology appointment scheduling as well. By the time the COVID crisis hit in March 2020, we were quite used to and comfortable and confident with the MagSeed system, and we were very used to using this Centimag probe for tumour localisation. We chose MagSeed as there was plenty of safety data out there to support its use. There's a number of relatively novel localization systems and devices on the market now, including radar and radio frequency identification, but MagSeed is by far the most utilised and reported on in the literature. In fact, in a recent meta-analysis published in 2020, looking at 16 different MagSeed studies, the localization success rate was over 99%, and overall re-excision rates were around 11%. Our own unit data, since its introduction into our systems, has revealed an initial learning curve. In the first 50 MagSeed excisions, our re-excision rate was around 15%, but now they're settling to an average figure of around 9% after 100 procedures done. Pre-COVID, we were still using the standard dual technique for sentinel lymph node biopsy. In Manchester, the radiopharmaceuticals we use are made and supplied by the Christie Hospital, which is around 10 miles away from our hospital site, meaning that patients listed first on the list for sentinel lymph node surgery were given a radioactive isotope injection the afternoon prior to surgery to allow more theatre efficiency and better theatre scheduling. The nuclear medicine site is actually on site in North Manchester itself, and the isotope was always delivered and given by the staff there prior to the surgery. Suddenly, however, in March 2020, when COVID phase 1 hit, all elective surgery was stopped at the North Manchester site due to staffing and bed pressures within the hospital. At incredibly short notice, we had to make the decision to move the service to a cold day case surgery site within Rochdale Royal Infirmary, another 10 miles away from our normal site. There were some immediate concerns with this, and we had to make them work. There was no nuclear medicine department there. There was an unknown clinical risk of asking patients to attend North Manchester General Hospital for an isotope injection either the day before or the day of surgery. So we were unclear as to whether this was a good idea or not. We were reliant on new theatre staff with no or little experience of breast surgery, who therefore didn't know the safe disposal and handling of the radioactive specimens and waste. The safe and steady supply of the radioisotope couldn't be guaranteed either, particularly with all the changes that COVID brought with it. And there was also no acute medical cover at this new day case service. And although in the majority of cases there's been no issue at all with the patent blue dye, there is a reported risk of anaphylactic reaction. And we were a bit concerned if this were to happen, we didn't have the backup we'd need. So we started to wonder whether there was a magnetic solution available to us here as well. We were very, very comfortable and confident with the seed localization and the Centimag probe. MagSeed had worked really well for us. So we started to think that maybe we could use an alternative to radioactive isotope and blue dye. We saw that MagTrace offered some advantages of being able to be injected on the day of surgery. Its localization in theatre relied upon the MagSeed and the Centimag system we were comfortable using, and the literature available revealed absolutely no reported case of anaphylaxis to MagTrace, which again was a huge bonus compared to the use of patent blue dye. There was also plenty of data to back its use. It showed it's safe, it showed it's comparable and non-inferior to the dual tracer technique that's currently used as standard. We therefore went about presenting a small proposal paper to our New Medicines and Devices Committee within the Trust, and then had to present the same paper to the Silver Command Committee within the hospital due to it being part of the COVID crisis and the COVID planning. As a team, we decided not to go gung-ho, not to go straight in, but to actually approach this in a staged approach as it was completely new. So to avoid any potential problems with localization, with the concurrent use of MagSeed and MagTrace, we decided to just stick to mastectomies to begin with. We also used it in conjunction initially with patent blue dye as a fail-safe system that we were used to using. Once we became comfortable with this, our next 5 cases were actually done in palpable wide local excisions, just to get that used to using a smaller incision and a smaller exposure to the axilla before then moving on to all cases. So we have some videos just to explain and show you how easy MagTrace is to use within the theatre. This is to show you the injection to start with.
So we're going to inject this in the subareolar plexus. And the key here is to make sure that you get deep enough that you don't cause any staining of the skin, but you don't want to go too deep because it'll take longer for the transit time. So we just, a little alcohol here. And the key really is just at the edge of the areola, in that little pocket there, just below the nipple. And when you inject it, if you're in the right place, it should go in very, very simple. So you can see that the MagTrace is going in nice and easy. You're not getting any blushing in the skin, so we know we're in the right place. Draw back as you come out.
So I would say it really is as easy as it looks. Finding that plane is really simple, and the staining of the skin is certainly a lot less than it you see with patent blue dye. Moving on to showing you the massage. So the massage is an integral and essential part of using MagTrace, and to ensure its success, it's really important that's done for the full 5 minutes. We have to be really strict with ourselves when we're in theatre that we time that really well. And this is just an example of how that's done.
And then really the key is the massage. So once you've injected it, now it's critically important to do the 5 minute of the breast massage to get the lymphatics to take up the MagTrace so that it goes to the axilla in a timely fashion. So we do a 5 minute massage. Then with the PEX blocks, we'll get about another 15 to 20 minutes. So the total time before we even start in the axilla will be at least 20, if not 25 minutes. So that should give us plenty of time to get transit into the axilla. But you can see this is a true massage to get that flowing through the lymphatics to the axilla. And so we'll do this for about 5 minutes.
So moving on to finding the transcutaneous signal. So this demonstrates how you can find a signal within the axilla. It does take some time, so you have to wait for that massage and the transit from the breast to the axilla before you can find that transcutaneous signal. But it is there, and this demonstrates this well. So moving on to our data, within our first 15 cases that I can present to you today, I hope you can see from this data, I know it's probably quite small on your screen, we did manage to find a hot node in every single case. So the Centimag did not fail to find a sentinel node biopsy in our first 15 cases at all. In some cases, in 2 cases that are marked green, only the hot MagTrace worked. It didn't work with the blue dye. So there are 2 cases where if we'd used blue dye only, we may not have found a sentinel node at all. We would have to have done an auxiliary sample. I've also highlighted case 6 and 14 that show that the hot MagTrace signal found pathological lymph nodes in both of those cases. So we know we're getting an accurate result using the MagTrace. This audit compared both hot non-blue nodes with hot blue nodes and only blue nodes. So in a couple of cases, there were only blue nodes. However, in both of those cases, there were also hot blue nodes as well. So I'm not sure that the blue node, the blue dye added anything to our sentinel lymph node biopsy at that stage. So, in conclusion, we feel that the total magnetic conversion of our breast lesion and sentinel lymph node biopsy systems has enabled us to be able to respond to the different and challenging demands of the COVID pandemic. There is a learning curve with this technique, and safe introduction is dependent on the whole team buy-in and agreeing and wholeheartedly agreeing on exactly how you're going to introduce that and which cases might be the best cases to start with. And there needs to be careful prospective audits of all our outcomes, and those audits are only possible in our department by buy-in from a theatre team who collect that data for us at the time of surgery. We've now moved on to using MagTrace in conjunction with MagSeed localization, and we've not noticed any problems, no matter what quadrant the MagSeed is in at all in the breast. We find that if we use the probe to locate the MagSeed prior to injecting the MagTrace, there's absolutely no interference at all, particularly when you use this periareolar technique with the MagTrace injection. I don't think we'll be going back to the traditional standard method. Many thanks.
Thank you, Kate, for the lovely presentation and talk. If you don't mind, stop sharing your screen. That's great. So that's a lovely talk, Kate. Many thanks for that. Everybody, there's some comments about the quality of the slides. I think there's issues with the broadband in some places, and that's why the quality is a bit less. I have an actual copy of this presentation because this is the first time that we try to pre-record some of the talks, and we'll see if we can also share that on the YouTube channel later. I have some people on the YouTube channel that has sent me messages to say that on the YouTube it might be slightly better. But as you noticed today, we have nearly 600 people online. Last time we had only 500, mainly because that was a package. So we have now sponsors, so we have some more money to be able to upgrade the package. That's why we have more than nearly 600 people online. Also for the certificates, we've teamed up with a company that will be issuing the certificates, so I don't need to sit and do 500 certificates for people. Even if it takes a minute, that's about 10 hours worth of work. So it was a nightmare for me. Sorry for the people that haven't received certificates yet for the previous webinars. If you want the certificate, please email me. If you don't need it, please don't, because I need to do the previous ones. But for this webinar, automatically in the coming few days, you should receive your certificate if you attended on Zoom online in the coming few days. So fingers crossed with that, the system will work okay. Great talk from Kate. And now, Ash, you're introducing the next speaker.
Yep. So, Peter, if you want to put your slide share on while I'm talking. So it's a great pleasure to introduce a colleague and friend, Peter, from the Royal Marsden. So Mr. Peter Barry, if most of you don't know, comes originally from Sydney, Australia, and moved to the UK in 2000 when he joined the Royal Marsden. Very active in the field of innovation and a very good colleague in terms of working with innovations. Maintains a very strong interest in translational research as well. Welcome, Peter, and he's going to talk to us about targeted axillary dissection, post-neoadjuvant chemotherapy using magnetic node markers. So the floor is yours, Peter. Thank you.
Thanks for the very kind introduction, Ash, and certainly enjoyed Kate's talk. This is going to be a little bit different. We're going to concentrate on mag seeds, and I'm going to assume quite a bit of knowledge about targeted axillary dissection and how we made that work. So I'll start the talk now. Good evening, and I'd like to thank Yazan for the invitation to share with you our early experience of targeted axillary dissection using mag seeds in the axillary nodes for breast cancer on behalf of the breast unit at the Royal Marsden. I have no disclosures, but the Marsden does host surgeons and radiologists who wish to see and learn the process, and I certainly extend the invitation to any of you who'd like to come and visit us. The mag seed is a tiny stainless steel pellet with a helical texture, just 1 millimeter in diameter and 5 millimeters long, and its paramagnetic qualities in conjunction with the Sentimag probe means that a signal is generated that is read out here on the display, dependent on the proximity of the probe tip to the mag seed device. The closer it is, the higher the signal. The introducer itself is just an 18-gauge needle, which our radiologists use under ultrasound guidance to deploy the MAG seed accurately within the lymph node. And assisting this is a small wax bolus that stops premature dislodgement of the actual MAG seed. Now, we know that there are many alternatives to MAG seed devices, such as I-125 iodine seeds, which are radioactive. Wires, of course, a very traditional method for both breast and axillary localization. Colloidal carbon tracking, RF tagging, and other methods as well. What are the potential benefits here? Well, from a patient perspective, the localization of the lymph node can be uncoupled from the day of surgery. There are no wires sticking out, but furthermore, with MAG seed, there's no radioactivity. From a radiology perspective, it's very easy to insert, and it can be done at a convenient time, not during a busy one-stop clinic. From a surgeon perspective, transcutaneous identification, particularly in the axilla, is extremely simple. The downsides, of course, are that due to its paramagnetic qualities, there is artifact causing a signal void around the MAG seed for about 3 to 4 centimeters when certain MRI sequences are used. And despite this, however, it is safe to have a MAG seed in place if the patient does need an MRI, and it's been tested up to 3 Tesla. Surgeons need to use non-ferrous retractors when performing the procedures, as this interferes with the magnetic signal. And of course, cost may be an issue, but I will show that in the axillary context, it's probably even more cost-effective than for breast localization. The background in the Marsden, we first started using MAG seeds in the breast, of course, and my colleague, Miss Rusby, led this study of 100 wires versus 100 MAG seed cases, our first cases at the Marsden, and she showed clearly that there was a workflow improvement and more efficiency in theatre, although this wasn't statistically significant. But what was highlighted was a lower specimen weight in the wide local excision cases. And I draw your attention to the article published by Katerina Mika et al. On this. Well, to set the scene for the axilla then, which I'm going to completely focus on now, we can see the lymph node on ultrasound as a hypoechoic structure. This is about 14 by 4 millimeters. And you can see the needle deploying the MAG seed, the latter which you can see easily in the node as an echogenic line in the lower panels. You can see the radiologist here demonstrating the ease of use of the introducer. There's a small separator that's removed, and then the needle can be advanced to a certain point. And as I mentioned, there's a small wax bolus that stops the pellet dropping out of the needle. This means that it can be used with a single hand technique, while the other hand uses the probe to accurately locate the node with this procedure. And here is a video showing the procedure in real time. And on both panels, you can see the needle approaching from the left of the lymph node. On the left side, we have a large de novo abnormal node before chemotherapy. On the right side, the node has been responded to chemotherapy and is much tinier and fibrosed and is therefore more challenging to insert, and of course is a smaller target than that seen on the left. And you can see just now the seed deployed within the lymph node. What about the context? Well, firstly, as I mentioned, we started off and we have now done over 500 breast localizations, but our experience in the axilla is relatively early, with 83 attempts at axillary MAG seed insertion. And of these, most were successful, and I'll go through the figures in detail. And there are 3 scenarios I'd like to discuss. Firstly is with the use of MAG seed in the axilla. We have 45 patients who were planned for neoadjuvant chemotherapy with node involvement at the outset. And our standard of care is to perform an axillary ultrasound at diagnosis, then an FNA or core biopsy of the abnormal node on ultrasound, and insertion initially of an O12 marker prior to neoadjuvant chemotherapy. When we started, this was our practice, and this is the tiny O12 marker, which is about 2 millimeters in diameter. It's very stable within the lymph node, but there were difficulties. The challenges were that, firstly, for the radiologist, if the node had responded very well and was difficult to visualize on the ultrasound at the end of chemotherapy, the O12 was difficult to see. And therefore, not all the MAG seeds could be inserted. Furthermore, we struggled as surgeons, not to mention struggled training our trainees, to locate the nodes with these O12s because they were very difficult to find in some cases. We had to X-ray the nodes, which caused delays. And I must say we caused excessive trauma to the axilla in trying to locate them. Well, we then transitioned, firstly, when we started using MAG seeds in the axilla, to inserting the MAG seed at the end of chemotherapy with the O12 in place. Now, this is 32 cases we did this for. They had the prior O12 as mentioned. And unfortunately, in 3 cases, the O12 marker could not be seen as the node had normalized completely. And so from an intention to treat point of view, these cases were abandoned. The MAG seed was inserted but not found in one of the lymph nodes, where it was found in the fascia and later on the surgical drape. Aside from those 4 cases, we were successful in locating all the other nodes, but the radiologists did report that it was much more challenging to insert at the end of chemotherapy. And of course, these cases were selected for their good response, otherwise we wouldn't have indicated to do a targeted axillary dissection approach in the first place. The median age of these patients was 52 years, with the usual range, and notably, 3/4 of our patients were either HER2 positive or triple negative in receptor status. Here is an example of a lymph node, just 4 millimeters, but clearly abnormal. And you can see how difficult it can be, although visible in this image, to see the O12 marker. It's the small echogenic ring. It's quite difficult to see. This is only a few millimeters in diameter. Again, here is the MAG seed, and again, without the hypoechoic large node, it's very difficult also to see that on occasion. Well, the next step in our transition as we progressed through this process was to insert the MAG seed at the beginning of neoadjuvant chemotherapy and abandon the O12 marker altogether. We had 13 patients in whom we've now inserted the MAG seed initially. It's certainly easier for the radiologist to perform this. And we did, however, note that there may be possible interference with patients having breast MRI. But at the Marsden, in fact, our default position is to use ultrasound to monitor treatment response, both in the breast and the axilla, in particularly in the axilla. And MR use is quite exceptional. If we do have a patient in whom MR is required, then, of course, patients in whom the primary was within 3 centimeters of the axilla were excluded from having a MAG seed at the outset. And so far, all nodes have been successfully found and removed in 11 cases out of the 13. And this is a possible pathway to the ATNEC trial, a UK-led trial of neoadjuvant chemotherapy, and when there's a complete pathological response to the treatment in the axilla, then patients can be randomized to no axillary treatment or else radiotherapy or surgery to the axilla. Well, here's a patient example, a recent diagnosis. We can see the axillary node here on the PET CT, very FDG avid. Here's the breast primary, and again the node shown in the axial section. This shows a MAG seed placed at the outset in the breast primary, but also in the rather large and easily visible hypoechoic but very abnormal lymph node. Well, what were our results? In the 41 cases that were successful out of 44, the HER2 positive cases had an 80% PCR rate in the axilla, such that only 4 out of 20 nodes had residual disease, but all the other non-sentinel nodes were clear. In triple negative setting, in triple negative patients, the PCR rate was 73%, and only 3 out of 11 had residual disease, but all these patients had disease beyond the index or sentinel nodes during our axillary clearance. And the same with our luminal B patients, again, quite a high PCR rate in the axilla, but when it was positive, we always cleared and we found residual disease. But this highlights the fact that one can conserve the axilla in the majority of patients in this context. The PCR rate may be thought to be abnormally high, but of course we are biased here because we're selecting insertion of mag seed for those cases who have responded well. And this is a video to illustrate a procedure done by my colleague Ms. Krupa. First, we zero the probe to calibrate it, and then you can see the probe showing a very high signal in the axilla. And then, interestingly, in this case, the sentinel node showed radioisotope uptake and was also blue, but in fact, it's the node underneath that you can see the magnetic signal actually emanates from. And it's the non-blue, non-isotope positive node, and you can see the node is not pigmented. And in fact, there was no uptake of isotope in this node, and in fact, this node was the only positive one, i.e. the true index node with the mag seed within it. So how do we simplify the workflow as well as the patient journey in the context of neoadjuvant chemotherapy? Well, in this cartoon, I want to take you through our process prior to using mag seed and show how we transition to simplify the process. We performed the diagnostic axillary ultrasound, as I mentioned, proved that the node was involved pathologically. This was obviously upsetting for the patient. The radiologist can be seen above the patient there with a diagnosis made. And then, of course, the patient had to return prior to chemotherapy to mark the index node, and as I mentioned as we started, with an O12 marker. This caused more concern for the patient with a second interventional procedure prior to chemotherapy. And of course, the radiologist found this challenging but satisfying. Chemotherapy was then undertaken with axillary ultrasound to monitor response in the axilla. And then the pre-op consultation was interesting because patients were always shocked that we then had to insert yet another marker. But doctor, I've already got a marker in. Well, we'd explain, of course, that the first marker was not reliably identifiable during surgery, and therefore we advised the insertion of the mag seed node at this stage to remark the index node. And of course, this was another procedure for the patient who then had even more concerns about potentially getting COVID-19 due to further exposure to the hospital. And then, of course, at surgery, we'd perform dual localization, identify the index node using the mag seed and centimag probe, remove it, and then remove the non-index sentinel nodes, and then test all. And we are lucky enough to be able to do this intraoperatively using OSNA. But of course, sometimes a second procedure will be required to manage the axilla in appropriate fashion. Now, how did we then simplify this? Well, as I mentioned, we transitioned to omit insertion of the O12 marker, inserting the mag seed after the diagnostic procedure, once we'd proven that the nodal involvement existed, and to place it in the index node prior to chemotherapy. And this made the patient a little less unhappy. But importantly, it meant that we could skip the final insertion, and this certainly obviated the need for a further marker placement prior to surgery. So saved a very important and crucial step in the process. And I think you can already begin to appreciate how this then becomes very cost effective if we take the savings into account from not having to put an initial marker in. And this is our current situation and management flow as it exists today. And one wonders for the future, and perhaps slightly controversially, but perhaps in selected patients, we can move this even into a one-step procedure where during the diagnostic biopsy, for example, with a U5 radiologically very definite malignant features of the node, to insert the MAG seed already in the largest node at that point, to mark the index node in the single procedure. And I think the radiologists would think that this is very cool indeed, saving yet, of course, another procedure for the patient. So I'm now going to talk about the scenario of what we call primary TAD at the Marsden, where we've done 30 cases. And this is in the context of patients having primary surgery. So what do I mean by this? Well, there's a unit approach to try and de-escalate axillary surgery. And of course, the problem nowadays that we face is that radiology and axillary ultrasound in particular are very sensitive. They will pick up very tiny solitary nodes, which they will designate as anywhere from U3 equivocal to U5 definitely malignant, and of course biopsy prove these. But using Z11 or our POSNOC criteria, which is another UK trial, similar to Z11 in some ways, whereby T1 or T2 primary cancers who are deemed to undergo primary surgery, i.e. usually they're ER positive, HER2 negative, thought not to respond to neoadjuvant chemotherapy, with 1 to 2 positive nodes, could be spared axillary clearance by these criteria. And they may be micro or macroscopic nodes, of course. Now, the options in this situation are that we do no axillary treatment beyond the removal of these 1 or 2 lymph nodes, or that we offer patients axillary radiotherapy or surgery if they so wish, or we can enroll them and randomize them within the POSNOC trial in the UK. Now, here is a patient having a MAG seed inserted in the primary context, quite a small node, and you can see the resistance there until the needle penetrates the actual capsule of the node with the MAG seed deployed. But this is what we've been doing in patients who undergo primary surgery and have just 1 abnormal node visible, possibly up to 2. And you can see again the characteristic appearance of the MAG seed in the node. We have 30 patients, and their early results, median age 58 years. And you can see in this population now, 80% of our patients are ER positive and HER2 negative. The O12 was inserted in 6 of these patients initially, as the treatment plan was a little uncertain before we got the actual diagnosis and knew the phenotype, the receptor phenotype for the patient. 3 out of 30 patients, in 10%, the marked node was actually not malignant. Now, you could say that this was a wasted procedure, but in fact the node did look abnormal, and in many cases where we have a U3 or U4 node, of course, we will find that the node is involved. But in this series, 3 were not. In a further 16 out of 30 patients, they had only 1 or no further nodal involvement apart from the MAG seed targeted node, and were therefore able to be spared axillary lymph node dissection. In a further 11 patients, we tested at least 2 further nodes and found that the patients had more than 2 nodes involved, and therefore they did undergo axillary dissection. And this shows that we can spare approximately half the patients in this context from clearance despite a positive node. Well, the final scenario that I'll just touch upon now is potpourri of other indications, including stage 4 disease where there's nodal positivity and maybe activity on a PET scan or ultrasound, where we'll mark the node, and then in the case where there's progression, use the MAG seed to target removal of that node where we don't want to cause a significant trauma by axillary lymph node dissection. Similarly, in an axillary recurrence where there's a single node recurrence after previous clearance and or radiotherapy, we will use MAG seed to target the node where it's impalpable, and this has been incredibly helpful and really cut down our operating time. There are 2 cases of hematological malignancy where this has also been useful as we provide this service at the Marsden. Finally, I'd like to acknowledge my surgical colleagues, in particular Ms. Rusby, Ms. Krupa, and Katerina Mika. And last but certainly not least, my radiology colleagues. And I really want to highlight, and I've said this probably and emphasized this during the last 20 minutes or so, that without good radiological localization, of any marker within the axilla, and in particular the mag seed, really we have no hope as surgeons of doing a good operation. So we're completely dependent on our radiologists. And I'd like to just offer a message to everyone that to get together with your radiologists, develop a good relationship with them, see how they actually do the procedure, and get their feedback when it comes to axillary localization. And remember, if it's easier for them, it'll make our lives as surgeons much, much easier, and of course, minimize trauma to the patients that we treat. Thank you.
Thank you, Peter, for a brilliant, succinct, and very precise presentation, touching on all the salient features that one would expect in a targeted axillary dissection, especially beyond targeted, where you've spoken about Castleman's, you've spoken about recurrences. I think these are new novel indications and great for introducing that flavor to the end. And radiology, of course, agree completely. If your radiologist once can make your life really miserable. So I'll hand over to Yazan. I think we'll take the questions at the end. I'll hand over to Yazan for Jill and the next presentation. Thanks again.
Great talk, Peter. Many thanks for that. And great to see that Tanya is enjoying her time in the Marsden with you, the new radiologist who ran away from us from Aberdeen and came to you. I always say we're as
indeed
good.
our gain.
Yeah. Also took badge from us.
Yes.
That's right. That's right. I really shouldn't be putting the names up. It just shows how dreadful things are.
And this is the second webinar. That last webinar, this webinar, the future webinar is all about de-escalation. We're not saying that this is the only way of doing it. And different parts of the world will do different things. It's just an eye-opener how other people might do it. So last webinar was about round blocks, lateral mammoplasties, about smaller mammoplasties that you can do, bigger excisions with them. It's not only about doing big wise patterns. This webinar is about the escalation of the axilla, and the webinar in 2 weeks' time is the escalation of breast surgery in general, where we have many speakers from Europe. But for now, we'll have the experience from the States. And it's a pleasure to have Jill Dietz, and Jill is the current president of the American Society of Breast Surgeons. It's great to have her here. She's one of the surgeons from Ohio, and she'll be talking about their experience in the States, and they have a very impressive large cohort that she wants to share with us. Jill.
Much appreciated, Yazan. I really enjoyed Kate and Peter's talk, and it's really nice to see how our colleagues across the pond are utilizing this technology. I think you might see that everyone has their own adaptation for these uses, and I will share mine with you. Bear with me as I try to share my screen here. Is that working?
That's working great.
All right, I'll let it rip.
Thank you, Dr. Massanat, for inviting me to present our experience and contribute to this webinar, Managing the Axilla, Less is More. So we know that axillary conversion rates can be as good as 70% after neoadjuvant systemic therapy in some cancer subtypes. Sentinel lymph node biopsy after neoadjuvant systemic therapy is accurate, particularly if we use dual tracer, if we remove at least 3 lymph nodes, and we remove the clipped and biopsy node. Using this technique, we can save many patients from having to undergo both a lymph node dissection and radiation therapy, thus saving many of the complications of lymphedema, shoulder immobility, and chronic pain. One study showed as many as 25% of patients with a core needle biopsy that was negative had a positive sentinel lymph node at the time of surgery. Our early institutional data showed a false negative rate for core needle biopsy to be as high as 18%. After we found this, we started clipping and localizing all abnormal biopsy lymph nodes. In early 2017, we transitioned from wire localization to MAGSI localization for our targeted lymph node dissections. Just a few days ago, MD Anderson published their targeted axillary dissection experience with MagSeed. There were 50 MagSeeds placed by 17 radiologists. 98% showed the seed and the clip in the same lymph node. Their experience found that MagSeed was safe and effective and very easy to use by the majority of their surgeons. Last year, we published the largest non-radioactive seed experience in the United States. This was an IRB-approved prospective trial with 6 breast surgeons, 7 radiologists in both academic and community hospitals. We had 832 MagSeeds placed, 136 of those in axillary lymph nodes. Our MagSeed and lesion retrieval rate was 99%. We then started to look at just the subset of patients having ultrasound-guided core needle biopsy of abnormal appearing lymph nodes. We found 242 of such biopsied lymph nodes. 98 or 40%, the biopsy was benign. 45% of these patients, due to clinical features, underwent neoadjuvant therapy, and 6 of these were found to have malignant sentinel lymph nodes on surgical pathology. 8 of the patients who had no systemic therapy were found to have malignant lymph nodes on surgical pathology, despite the fact that their core needle biopsy was benign. This is a false negative rate of 14.2%, although we expect it to be much higher because many patients who underwent neoadjuvant systemic therapy converted to benign, and these patients aren't considered in this calculation of the false negative rate. So our seed retrieval rate in the axilla was 98%. Our clip retrieval rate was a little less than that because we use a ultrasound detectable gel clip, and sometimes the hydrostatic pressure squirts the clip out and it gets sucked up into the suction. We did find, however, there were many benefits of a wireless localization, including on-time starts with increased OR efficiency, ease of scheduling. These clips were able to be placed in an outpatient facility, and then the seeds were able to be removed in surgical facilities that had no radiology present. We were able to dissociate the localization in the radiologist from the day of surgery, which freed up the radiologists. It was always nice to not have a wire that was taking an abnormal trajectory or going through the muscle. And for the patients, it was a great experience because they didn't have to undergo any additional procedures the day of their surgery when they're already anxious and NPO. After about October of 2019, right after the FDA approved MagTrace, we began using this iron oxide nanoparticle as a dual tracer. This is shown to be non-inferior to a combination of technetium-99 and blue dye. I would say the most compelling characteristic of MagTrace is that, unlike other tracers, it stays in the sentinel lymph nodes for weeks. We did 190 cases at the time of the analysis. 165 had a sentinel lymph node biopsy or lymph node dissection, and 25 had a Sentinot procedure. The Sentinot procedure was first described by my friend Andreas Karatkasanis and his colleagues from Sweden. For this procedure, which is performed on patients who have ductal carcinoma in situ who are undergoing a mastectomy, the MagTrace is injected into the subareolar area and massaged for 5 minutes. 20 minutes after injection of the tracer, the mastectomy is performed. The sentinel lymph node is identified but not removed. If the pathology report shows invasive disease a week or 2 or even 3 after the initial surgery, then the patient can return to the operating room for excision of the sentinel lymph node, and the mag trace will identify it because it'll still be in the initial sentinel lymph node. Our mag trace localization experience of 190 cases with 165 sentinel lymph node biopsies or axillary dissections and 25 sentinel cases was about half and half with breast conservation and mastectomy. The age distribution was consistent with other invasive cases. Histology was mostly invasive ductal carcinoma, about 20% DCIS. Because there was a large proportion of patients undergoing neoadjuvant systemic therapy, there was a MAG seed placed in 18% of the cases. And because this is an initial experience of our institution and a learning curve of several of the surgeons, there were multiple tracers used in 22% of the cases, most of that being technetium. We had a success rate of 97% in finding the sentinel lymph nodes. There were a few failures, and I should say that most of these were in patients who had previous lumpectomies with node dissections and radiation as well. There was one case where there was no tracer detected. For the sentinel cases where the mag trace was injected and no lymph node dissection was performed, 3 of the 25 were found to have invasive disease requiring a return to the operating room for sentinel lymph node biopsy. All 3 of these had successful identification of the sentinel lymph node. Thus, 88% of our DCIS patients were spared axillary surgery. For the 165 cases, 160 or 97% had successful identification of the sentinel lymph nodes. All the cases that had multi-tracer techniques were also found to have mag trace uptake. Some of the lessons we learned using both MagSeed and MagTrace: it's probably better to stay with no block or only intrapectoral level 1 blocks, as level 2 and 3 pec blocks can interfere with tracer migration. Make sure you massage vigorously for 5 whole minutes. Don't skimp at all. And also, when you go to listen for the signal through the skin, it can be very minimal or missing. But in very few cases did we not hear anything once we got to where we knew the lymph node was. When doing a lumpectomy, we're using a mag seed and mag trace. Make sure the seed is not too close to the nipple, because the mag trace can interfere with identifying the mag seed. It's best to actually mark the skin of the seed location before injecting the mag trace so you know right exactly where you're going for the lumpectomy. Once you make the incision, whether it over the around the areola or through an oncoplastic incision, separate the nipple with the mag trace from the area to be removed to assist with being able to hear the seed. And you can actually even remove some of the stained lymphatics in order to be able to better hear the seed. My recommendation is to use technetium 99 as a backup for your learning curve instead of blue dye, so that you can not visualize the blue dye and rely on the mag trace, both the brown and the auditory, for finding the sentinel node. And if you cannot find the sentinel node with it, then you can always use the technetium as a backup. We found great value in using MagTrace. It eliminates the need for another tracer over time, and that decreases the expense. There's no radioactivity or regulation or anaphylaxis risk or necrosis risk which can be associated with blue dyes. You can inject this days and weeks ahead, or you can inject it when the patient is asleep on the table. We're able to use the same equipment for MagSeed breast localization as MagTrace sentinel lymph node localization. And another thing is, if you're using MagTrace in the breast to identify the sentinel node, you can actually use isosulfan or lymphozurin blue dye in the arm for reverse lymphatic mapping. And I think most importantly, you can actually spare DCIS patients who have to have a mastectomy or a large oncoplastic procedure from a sentinel lymph node biopsy in the majority of cases. So, are there any downsides to MagTrace? Well, one might say that you have to use non-metal instruments. I tend to use my lighted retractors, which are non-metal anyway, for a lot of my oncoplastic procedures. And I've also found these cheap disposable plastic retractors to be just the right size for a sentinel lymph node biopsy. Now, this is a patient who had an oncoplastic procedure, and you can see she has a blush of MagTrace still present as she's beginning her radiation. This is also a staining from the MagTrace injection in the subareolar area. Even in nipple-sparing mastectomies, where you inject MagTrace in the subareolar area, you can still see a faint stain on her skin from the subareolar injection. MRI artifact can be seen after a subareolar injection of MagTrace. And you can see here a small amount of artifact, and this could be seen for over a year after the injection. Here's a sagittal view of this, a blush of artifact behind the areola from a MagTrace injection. So I hear coming down the road, there's going to be the next generation of the MagSeed and the CentiMag units. The new MagSeeds will be able to be placed at the time of the biopsy and will have very minimal MRI artifact. The new CentiMag units will be able to differentiate between a MagSeed and a MagTrace by flicking a little lever. This is going to allow us for a deeper injection. It's going to allow earlier injections, days to weeks ahead of time, and allow us to use less MagTrace. Also, it'll allow the MagTrace in the tumor bed to be removed, limiting the MRI artifact and allowing for less staining. I know there are some units in Europe who are using this technique successfully, but the new CentiMag unit will be able to eliminate this problem for most. It might even be possible to be able to use titanium or metal retractors with the new unit, which will also be much smaller. In my experience, MagSeed and MagTrace has been able to assist us with providing high-value care to our patients with excellent outcomes of great patient experience for a reduced cost. And I couldn't have done any of this without my team at university hospitals, particularly Megan Miller and Eleanor Keller and Lee Fin Chow, who have been instrumental in help gather the data and write this experience. So thank you very much.
Thank you, Jill, for the lovely presentation. And you asked for Andreas, and Andreas is here now. And Andreas, how are you? You're on mute, Andreas. How are you?
Hi, I'm fine. Great talks, everybody. Very nice to see you. Hi, Jill. Hi, Peter.
Hi.
Now, we had some comments about the slides, and you're not seeing them as clearly as previous talks. This is the first time we try pre-recorded talks, so if you feel that the slides quality is not as good as previous webinars, please feedback that to me, and when you do the poll at the end of the webinar, and we'll stick to the old live presentation type of thing. But we try to do this now because they're all high quality, high definition videos. So we thought that would be an better quality for everybody online. But sometimes with the broadband quality, that's not always achievable everywhere. So we might need to go back to how we used to do things. There's lots of questions and answers in the question and answer section. Many of them will be asked and answered live. And we need to thank the sponsors for Endomag as this is the first sponsored webinar. So thank you very much for being part of this. And I need to show just a 2-3 minute video for Endomag before we start the discussion. There's lots of points to be discussed about MRI scan, about localization, about different things in this technique. But I'll put this video and then we'll start the discussion if that's okay with everybody. I'll see if I manage to share screen. I'm not great in sharing screens now. Can you all see my screen?
Well, thank you, Yazan. It's been a pleasure listening to
Can you
these
hear the
fantastic presentations from our guest speakers this evening. I'd like to thank Kate, Peter, and Jill for sharing their experience in both auxiliary management techniques and also lesion localization with the SentiMag platform. Now, you've seen throughout these presentations, the SentiMag platform can provide a complete non-radioactive solution for both current standards and advanced techniques in the management of breast cancer. At Endomag, we understand the value and importance of high-quality clinical data to prove the efficacy of our products. MagSeed is now the world's most studied non-radioactive seed, with over 4,000 patients in published clinical trials, and this will soon exceed 5,000 patients when the UK eyebrow study results are released. MagTrace has even more clinical data and has been shown in multiple meta-analyses to be non-inferior to the gold standard of technetium and blue dye. And I'm very pleased to announce on this webinar, the indication for MagTrace in Europe has recently been widened. This will now allow a reduced volume of 1 milliliter to be injected preoperatively, but also can be injected up to 30 days ahead of surgery, which offers unrivaled flexibility during COVID and makes a delayed sentinel lymph node biopsy technique possible for mastectomy patients. Now, unfortunately, due to a perfect storm of the COVID pandemic and also Brexit, we understand that many sites across the UK are having issues with technetium supply, and some have been forced to use only blue dye for their sentinel lymph node biopsies. Now, MagTrace can provide a perfect solution to this, and we've been helping sites remove their reliance on nuclear medicine. So if you're an institution that's experienced these issues, please feel free to reach out to us, and we can work with you to solve them. Now, SentiMag was originally developed with the help of UK breast surgeons. And since its launch, we have now completed over 130,000 procedures with the SentiMag platform in more than 600 hospitals across 40 countries. But we're not stopping there. We are now able to leverage this global network of breast surgical oncologists and radiologists to develop the next generation of surgical guidance for breast surgery and auxiliary management. This new system will have new seeds that can be detected independently from MagTrace and also measured with millimeter precision, as well as seeds that will have smaller MRI artifacts than any other localization device on the market. Now, finally, I'd like to thank everybody who has come on to listen tonight, and especially Yazan for hosting this excellent iBreastbook platform. Our next webinar is going to be a presentation of the EyebrowNet lesion localization multi-center MagSeed study. Now, if you're not familiar with this was 40 sites across the UK who compared 1,000 plus MagSeed patients with 1,000 plus hookwire patients, looking at everything from re-excision data to accuracy of placement and more. We hope you can join us on February the 18th at 7 p.m. Please go to endomag.com to register for the event. Thank you.
So that's great. And back to us. Ash?
Hi.
So we're going to start the discussion. There's lots of questions and answers and discussions, and there's lots of points. There's a few slides that you wanted to share and go through things?
Yeah, I can go through this. Then I probably we can just do a few of the questions. Right, so sorry, that's me. So just because people have questions around MagSeed, and I think it's important that there are people I've seen from India and from Middle East. So basically what is a MagSeed is a steel helical structure, as Peter very kindly alluded to. A helix gives you a bigger footprint, and so it makes a bigger noise when it's in a magnet. It's about 5 millimeters, and as Peter said, has wax. The wax prevents it from slipping in the needle. Compared to the other two localizing techniques, which is Savvy Scout. The Savvy Scout seed or localizer device is 12 millimeters, so twice the size. And the localizer device is about 10.6 millimeters. The license for MagSeed is introduction with intent to remove. So you can place it for however long you want. It can be there for however long you want, but the intention has to be to remove. If you don't plan to remove it, you require a signed waiver from the patient. Why is the big noise about MRI scans and metal and MagSeed is because when you put a metal within a magnetic field, it gets hot. So it gets hot enough to cauterize the tissue around it, and it can migrate. And that's why there is this whole thing about whether it's MRI compatible or not compatible. And the MagSeed is MRI compatible. The only downside of the MagSeed is, like any metal, it creates a bloom or an artifact. And in special effect to MagSeed, it's about 3 centimeters in size. Now, lots of UK surgeons I can see online. So what's the cost? It's roughly about $250, depends on a distributor. But one thing that most of you don't know is that there is an HRG code, and I've used that code here. If you use this code and it's done as a standalone procedure, you can actually get back to 76 for it. So it's worth knowing this. Again, timing is based on whether you do MRI scans or not. Certain centers do an MRI scan throughout, and then it's done at the end. Or if you do an MRI scan upfront, then at the next ultrasound evaluation, which is halfway through the chemotherapy, the seed can be introduced. The axillary seed, as Peter rightly alluded to, doesn't interfere with the breast MRI scan. So it's very safe to put the axillary seed right at the start of the neoadjuvant chemotherapy, even if you want to go through with MRI evaluation of the breast. Now, it would be remiss of us not to mention pintuition, and I believe that the Marsden has done 1 or 2 cases. We certainly have no experience. We've had experience with MagSeed and especially MagTrace way back from 2015 when we did the first trials for MagSeed. The next, sorry, I'll try and go through these quickly. Then the MagTrace or SPIO, I mean, Andreas is here so he can tell us, but again, SPIO is nothing but a supramagnetic iron oxide particles. For the pedantic amongst us, it's 16 nanometers in size. One vial contains 2 mils. Again, it's about 200 pounds. Now, I know someone is asking about cost. If you take one of the nanocolloid vials, it costs about 348 pounds. You can use that vial for about 5 patients. Patent blue costs about 25 pounds. So overall, if you have 5 patients on a list, then the dual technique is cheaper. But again, if you do the injection of the MagTrace on the day before, you can reclaim 152 pounds, and that's the 157 pounds, sorry, and that's the HRG code that you can use. The new MagTrace is pre-mixed, and as alluded to, is licensed about 30 days after injection. Concerns about MRI scan, again, Andreas is here, but the Sentinel trial Jill alluded to was proof of principle. Data is published, showed perfect efficiency, perfect cost reduction, and a very good identification rate. And it was also allowing a dissection of central node, as Jill said, up to 46 days after surgery. Andreas, of course, will answer any questions based on that. The biggest problem is MRI scan, and this was one of the papers by Benedict Kirscher, which showed an MRI artifact. But again, then Andreas, of course, came to the rescue and published this paper where he said that if you use contrast, you don't have as much of a problem. If you go back to this other paper, which was published by the same team in Switzerland, which published the data for the artifacts, they proposed that if you change certain sequences and the way they're done and the acquisition, you can get rid of the noise. So that's your questions as far as MRI goes. And I think I will keep quiet now and open the floor up to questions. Thanks, Yazan. Yazan, you're muted.
I'm talking to myself. I'm talking to a mute microphone. So, Andreas, you have had published quite a lot on those techniques. And I remember when we did the webinar on new localization techniques, you talked about the magnetic and seeds in general. And it was an eye-opening thing when you mentioned about completely saving the axilla in DCIS patients for mastectomies. And we're already looking at our data and how many axillas we've done that we should not have or we did not need to do. So any comments, any questions for the speakers?
Well, for starters, I think that it is these were all very impressive talks. These were talks that were to the point regarding what we as surgeons want to accomplish, and keeping things like what Jill said about the value of healthcare that we provide and the experience of our patients in this setting, as well as the possibilities that the magnetic platform opens for us. I mean, the data and the thoughts that Peter Barry and then Kate presented are very, very eye-opening, as you said. We have been working with these techniques a long time, and these thoughts are not new to me. But what I would really like to know is what is the experience of other surgeons implementing things outside the box. So I would really like to ask Peter and Jill how they felt, like moving over, because Peter has been here in Uppsala. We have discussed, we have seen cases together, and I've talked with Jill, and she recently published a very impressive series of cases, a very big cohort. So I would like to ask what the learning curve was for them, not only in terms of loads of cases, but how could the unit transit from one way of thinking to another?
I could start if you want, Peter. We're trying to think about value when we rolled out our MagSeed experience, because it's cheaper for us to operate at our outpatient surgery centers, and we don't have radiologists there. So in order to really take the lower acuity cases out of the main hospitals, this worked really well for us. And we had trialed a couple different technologies, and I think at the time, again, this was in 2017, it was just much easier for the radiologists. So we really listened to our radiologists to be able to do a single hand placement of the MagSeed. And then it was really well liked by everybody, so it was very easy to roll out. I haven't put a wire in years. I bracket with MagSeeds, and I was just waiting for the Mag Trace to become available to start using that. I think the learning curve for Mag Trace is higher than for MagSeed. It's nuanced, it's tricky, and it's been slower to be adopted by everybody, but certainly for mastectomy patients with DCIS, it's a win-win. So that's our experience.
Yeah, Jill, I might go next. I'd echo what Jill said exactly. And in fact, what is incredible, the MagSeed and the axilla is just an enabling technology. I mean, the learning, I've never seen an innovation like that where the learning curve, I would say, is zero. I mean, from one day to the next, we went where I was scrambling around the axilla. My fellow, I wouldn't trust my fellow to do a TAD after NACT before we had the MagSeed. Now they just do them because it's just so easy. I agree with Jill completely. The learning curve for MagTrace is different. And I must say what transformed it for me was visiting Andreas and seeing exactly how he did it, because it is nuanced. The signal quantification is completely different to the MagSeed. And one thing I must say that helped me personally, and I would advocate for those who have the opportunity, is I do my own ultrasound, very similar to Andreas, and I was pleased to see. And I think I don't do procedures. I think Andreas probably does, but just seeing things on ultrasound just gives you such a better visualization. And what I have done now is I've injected MagTrace under the cancer myself under ultrasound guidance. And I think that is the next step for me and for us as a unit. We're just slowly progressing to MagTrace. So I think the other thing I would say to people, maybe introduce one thing at a time, one step at a time. And I think for us, that was the thing. Andreas is 10 light years ahead of us already. I realized we have to just go one step at a time, get one thing done in the unit. We've now got MagSeed done. The next step is to introduce MagTrace for us. So I think don't try everything at once. That's my thing. There were a few questions, just one thing too, just to answer with the primary surgical insertion of the MagSeed in the axilla, when you see one abnormal lymph node. One of the other reasons we started doing that is that we had a few cases, I didn't mention this in the talk, where we did the standard mapping and we didn't find the involved node. And that's very worrying because, you know, you have this tiny node that's biopsy proven and then you don't find it, you know, so you don't remove it. So that's what actually led us to start doing it in the primary surgical setting, to actually mark the node that was biopsy proven, because sometimes they were quite small. And the last thing you want to do is, you know, there's a node there, you want to leave that in the patient. You don't want to do that, believe me. And then that commits you to more extensive surgery if you miss it. So, but yeah, otherwise I echo, you know, what others have said.
And, I think many people, when they start new techniques, there's always a learning curve. I don't know and also this is something that is mainly used in Western Europe and the States. I'm not sure how much are they using this in other parts of the world. Omar, can you hear me?
Yes, I do. And in fact, I was fascinated today and quite impressed with the work and the presentations. And as I was sending to you right now, that we need to introduce this in Egypt. Yes. And when I was seeing the map in the presentation of Endomag, it looks to be a good technology. And in Egypt, as you know, we are mainly practicing, in the majority, is the simple blue dye. And we have very limitations in the COVID time and before the COVID time about the radioisotope tracers. It's not the easy thing unless you are working in one of the big university hospitals. And it's also not the everyday work. What we are acquainted to do in our daily practice here in Egypt is the simple use of the blue dye as the only sole identification method. So we are quite interested to follow the footstep and to introduce this here in Egypt and Cairo.
That's great. There's few people that have raised their hands wanting to ask questions and comment, and I'm not sure if they still want to ask those questions. There's lots of things in the question and answer, like, is it safe during pregnancy? How much is this going to cost if I use it locally? So many of those things will be dealt with locally by Endomag. So we just, when we send a follow-up email, you'll have some details and some contacts that you can contact people. But I want to remind Ash, it wasn't 2015, it was 2012 when you've done the Sentimag, because I was the registrar in Guys at that stage.
I just wanted to make a point and echo what Peter said. We made the transition, Peter and Jill, from using a wire in the axilla, which is one of the most painful things that I've seen a patient go through, and one of the most painful things for a surgeon to fish out. And when MagSeed came along, it was a no-brainer for us to switch. And believe me, like Peter says, the learning curve is so intuitive, the whole process. And and you know, we're not very clever as we, you know, surgeons. But it's easy for us to find it, and it was almost a bang. The target was there, and we've done now. We publish our comparative data, but we've always 100% identification rate with the axilla. I don't know whether Andreas wants to touch upon this dual thing that you do, which is fancy, and it's worth everyone knowing, is the seed on top, then the tumor, and the tracer at the bottom. So how do you use the same probe to differentiate?
So what we actually do, which is something that addresses the concerns about postoperative MRI artifacts, is that when the radiologist or one of us at the outpatient clinic localizes the lesion with the ultrasound, we just put the MagSeed in the tumor, in the anterior surface of the tumor, and then we inject the MagTrace just behind the tumor. If we have more complex lesions that are detectable with the ultrasound, what we do is that we put the MagSeed rather centrally, or depending on the localization, anteriorly. I remember that when Peter was here, we had a large upper inner quadrant, so we had placed the seed just in front of us, and then we had demarcated the entire area with the mag trace. This way, what you have during your dissection is that you never lose focality of the maximum signal with the mag seed, but you also see the periphery with magnetic signal and sometimes, or most of the times, brown stained. So the thing is that despite that the two signals overlap, you just know what is the area to remove. And once you remove it, once removing the bulk of SPIO, then you have no artifacts on the MRI, which is something that we have been following in a prospective study that we are running now here. Especially as Jill mentioned, the new generation, the new generation probe that will be able to differentiate the detection of the seed to the detection of the mag trace, I think that this is going to be a no-brainer, even for those that are hesitant. So I think that the way to go would be that, actually.
And Jill and Andreas, am I correct in assuming that if you give a peritumoral injection, then there is no skin staining?
In some 400 cases that we had published, we saw that the staining was some 3 times lower, much less in diameter and less intense on a follow-up of 3.5 years.
With peritumoral?
Yep.
Jill?
Interesting. Jill, what's your experience with the staining?
So when we first started using MagTrace, we were using a similar technique that was peritumoral, done by the radiologist. And that was, I think, the scariest part for me, because I was brand new using it and we really had trouble hearing the sentinel nodes. When we moved to a subareolar injection, actually in the operating room, I had no problems after that. So the vast majority of our cases were done subareolar. So we have much more staining and MRI artifact. So, you know, differences in technique, but I was concerned about being able to hear the mag seed because of the mag trace. So that's how we handled that.
That's great.
And question to Kate. You mentioned that you use blue dye and the the mag trace. So you've got two staining, potentially staining dyes. Where would you inject the blue dye if you inject the mag trace subareolar?
So actually, we put the two injections at the same place. So did the mag trace first and then the blue dye afterwards. To be honest, I'm now no longer using blue dye. That was just basically just as our fail-safe whilst we got used to the technique, and just to convince the surgeons that the mag trace worked, that we could find the nodes, because our kind of sister unit at the other end of Manchester, they'd been using the peritumoral technique that's been discussed here, and had problems with trying to differentiate between seed and nodes. So there was a bit of concern within the unit as to whether it would work well for us or not. We couldn't use isotope, obviously, for the reasons explained, as our fail-safe. That's why we use blue dye. But I find it absolutely fine without the blue dye.
And another question, if I may, to Jill and Peter, and obviously Andreas, is because it's a bigger particle, do you find that your nodal yield, if you use only the mag trace, is lower than if you use blue dye and isotope? So the number of nodes retrieved, median number?
No,
so
we did not find that. I think, you know, sometimes we would take out the mag seed and then find 2 other lymph nodes. I think the literature shows that the number of nodes removed with mag trace is the same and the same range as the combination of the tracer and the blue dye. So.
Andreas?
What I completely agree with Jill. What we have seen, both in terms of our daily practice and experience and meta-analysis of studies, is that you have more or less the same nodal yield. What we have seen in a dose trial that we recently completed and submitted is that when you inject more than 24 hours before the operation, what you gain is that you gain higher counts in the node, a much richer brown color, and less background signal in the lymphatics, which may be a challenge, as Jill suggested. So in this context, you may detect a little bit more nodes, actually, about 2.5, but you do not increase, you don't have problems like you would have with the ICG, that you would remove 8 nodes, for example.
And if I'm not wrong, just because we have students on this webinar as well, do we use the same principle in terms of counts for central node harvesting?
Yeah.
So do you mind just talking that through?
Well, all our studies and the technique is based on excising, stopping the excision when you have less than 10% of the maximum count. So this is the idea by convention from the very first sentinel lymph node trials. This is what we have been doing from the beginning.
And just to answer the question on pregnancy, I don't think there is any data for or against. But
that, Ash, if I may interrupt you, on that, we have been with Frederick Wernberry. We have been trying with the help of Endomag to organize a registry that we will be discussing whether if some colleague would have a case and they would like to consent the patient for that, because preclinical data does not suggest that it is not safe. It is again, by convention, we have not been doing it since the first trials had it as an exclusion criterion. That's the idea.
I think there's a few people that have raised their hand, and see if I can give them the microphone to see if they have any questions. Are you all okay with that?
Yes.
So there's Prof. Stefanos Zervutis. I think he's a friend of Omar, isn't it, Prof?
Yes, Professor Zervutis is one of the eminent breast surgeons in Athens, and he's also the president of the MANOSMED, which is the Mastology Association of the North and South of the Mediterranean, having a lot of publications, one of which is in relation to the site of injection, the intra-nipple injection for the blue dye. So
I'm not sure if Prof, because Prof has raised his hand a while ago, so I'm not sure if he still wants to comment or not. I've given you the microphone, Prof. Zervutis. If you want to comment, you just need to unmute yourself and talk. I'm not sure if they're still online or not.
no, he looks to be online. Stefanos.
Yes, Homer, can you hear me?
Yeah, we can hear you now.
Okay, yes. So, congratulations for very nice presentation, and I think it's the future. What I can say about the location of the injection for the detection of the sentinel node, we have done this technique now 10 years ago, and we described this first, and after us, many people do this in Lebanon, in Brazil. We inject the blue in the nipple, 1 centimeter behind the nipple. This has two advantages. First, the dye will go directly to the sape plexus, and then it is homogeneous, and it is, I think, more symmetric. And the second thing is that you have a very small point in the nipple, and you don't have problem of coloration that you have if you do it behind intradermic. This could be done, or of course, in any cases. We make massage 5 minutes, and we have published more than 99.8% of detection with the intra-nipple injection.
It's very interesting point. I've done my MD indeed with Kieran Hogan 3 years ago, and my MD was on the use of blue dyes and sentinel node biopsy. And I remember when I've done the first review is that peritumoral injection does not give you as much localization as subareolar and intradermal injections. So have you noticed any difference, especially sometimes peritoneal injection, especially for medial tumors, you might end up with the node in the internal mammaries rather than in the axilla. So have you noticed any lower identification rate if you inject around the tumor?
Yes, there are some differences, exactly. The thing is that when you choose the classical way to inject under the areola, in the upper or in the inner or in the out, in theory there is no reason to do it up or down. In the contrary, if you put it in the nipple, it will be symmetric. This will go to the circle of the lymphatic around the areola, and it will be homogeneous. And the sentinel node will be detected, I think, objectively, more objectively. That is the point. Yes.
Many thanks for that, Professor Fudi. So, Jill, any comments about that?
I guess my only comment would be if you injected magtrace within the nipple itself, the nipple would very likely turn brown and stay that way for a really long time. So, you know, I'm not sure that most patients would be happy with that.
And should we take some other comment? Many thanks, Prof. And if we speak, there's Tahir Masoudi. Tahir is one of the consultants here in the UK, so I can see he's, and I think Tahir is part of the IBRA-net, which runs many of those national audits. I'm not sure if Tahir, he's raised his hand, so I'm not sure if he wants to comment or not. Tahir, can you hear me?
Yes, yes, and I can hear you clearly. And yeah, I just wanted to ask thoughts from other colleagues about MagSeed. We have been obviously using it for quite a long time now. I was just recently, you know, I just felt short about one patient. There is a lady who had a big tumor, and we wanted to bracket her with MagSeeds. A lot of discussion took place, but ultimately the radiologist bailed out, and we just ended up using the wires. So I just wanted to know some experiences from colleagues about that. Do they do it regularly, and what did they find?
Many thanks for that. So do you do multifocal multicentrics? Do you bracket for bigger tumors? Do you use? So what's your experiences, all of you? So shall we start with Andreas?
Thank you. Yeah, well, we bracket. I have used up to 3 seeds, especially. This is something that has helped us a lot in the context of converting from mastectomy to complex oncoplastic breast conservation after neoadjuvant when the radiologic response is unclear. And this has been something that has helped us a lot. Then another thing that I have to tell you, what we have been doing in several cases, is that when you, for example, have a large area of microcalcification, where instead for 3 or 4 or 5, you will need a fence of mag seeds to demarcate the lesion. What we do is that we use the mag trace as a localizer. So you ask the radiologist in stereotactic guidance to, you know, inject drops in the perimetry, and then we just do it. And it's very simple, and it's much painless for the patient regarding if you would compare it to multiple wires.
But we don't have mag trace available in our unit. You know, we just have access to mag seeds.
So you can put more than one seed. I think that's what
worked for us without any problems. I would like to know what the other colleagues think also.
Peter?
Yeah, I agree. I've done up to 3 mag seeds to triangulate lesions, say a solid tumor maybe, and then microcalc, somewhere DCIS. But I completely agree with Andreas. The few cases I've had, just a handful, where I've injected magtrace posteriorly. And incidentally, when you do it in the clinic a few days before, you can reduce it to 1 mil, as Andreas has espoused, as well as Isabel Rubio. And again, that causes you know, even less signal out effect. But yes, you can very nicely outline the tumor, almost like the roll method without the radioactivity, just using magtrace. And so I think that's going to be something we're going to see more of. But you know, you asked the question. So, you know, 3 mag seeds, I think as long as they're more than 2 to 3 centimeters apart, it's not a problem to differentiate them. And it really is super easy, much easier than I think wires, where you have to work out not, you know, where they actually are in the breast, not where they're going in through the skin. So it is easier than wires.
Just sorry to interrupt again. You know, when the lesions, you know, when they couldn't localize it in a transverse plane, you know, if they wanted to localize it anterior-posteriorly, sort of, you know, that is where they raised their objections. I could see their point, because, you know, it's a 3-dimensional, you know, organ. When, you know, in the breast, when you have certain lesions which are in such a way that transversely it may not be possible to put two magseeds. That would be too close. So if the macrocalcs are extending from an anterior-posterior plane, then it's in that context that they raised their objections. So anyways, yeah, I mean, it is something we need to learn from, and with experience we'll know what's happening.
I think exactly what you said, Tahir. It's with experience, and many thanks for the comments. We use other technique, but it's very similar. And we start doing the ultrasound scan localization, then we move to stereo localization. Now, have you ever, any of you had the experience of the radiologist trying to put a stereo mag seed and it is not in the correct place? And what do you end up doing if that's the case? Because they are not supposed to stay, though in theory they should not cause any problem, but they're licensed to be put in as long as they come out. So have you ever had any problem like that? You're nodding your head, Jill, so you had this?
Sure. So I agree with what's been said. As long as they're 2 centimeters apart, instead of localizing the center of the lesion, you can put a seed on either side. For an AP spread, then usually our radiologist will do it with a mammogram and then come from lateral. And then, it doesn't even really matter if the lesion is medial, because there's no long wire to go through the whole breast. It's just the seed that's there. So that's helpful. On one occasion, I saw the mag seed was placed, and it must have been superficial enough that the seed caught on the dermis. And when the patient was taken out of compression, the seed actually came out of the patient. It was not in the patient. That was on one occasion. But I think the important thing is it was on the view of the compression view. I saw the mag seed in there. So I think the important thing is when the patient is asleep to find the seed, and if it's not there, then it's going to be obviously quite difficult. I actually used a C-arm and found the clip. It was a bit of a stressful day, but we got the lesion out. But that happened in 1 out of what's now been over 1,000 cases. So
that's great. And any comments about this, Kate? Did you have any difficulties? Do you use more than one seed in certain cases?
Yeah, we certainly used more than one. And I found it much easier to do the kind of complex oncoplastic techniques to take, multifocal tumours out. Certainly with our symptomatic patients, they can often have big lesions, and it's so handy to be able to have, two seeds, either end, so that you know exactly where you need to take, so then you can design your technique appropriately and accordingly, really. So definitely, it's what we do quite regularly in the unit, and I think we're all finding it much. So the main case that made us change from wire to mag seed was an older lady. She was in the 80s who had a wire guided excision. So we had all of that faff with her not being able to mobilize from unit over to theatre, a 2-hour delay in our theatre list, and then she got to theatre and the wire had moved. We missed the lesion, so she ended up having 2 anaesthetics, even though she was in her 80s. So that whole case and the whole patient experience and my experience and finding that really stressful was the reason why we changed to Magseed in the first place. And she had a wire that had traversed the whole breast, like we've discussed, where it had gone straight from lateral to medial. So that case is what kind of took us down this route in the first place, and is why we are where we are at the moment. So I find 2 seeds much easier than 2 wires.
For us, we've moved to those new types of localizations mainly because of COVID, because we're operating offsite now and trying to get a wire is not going to work. So 3/4 of our wide local excisions would not have been done during the first lockdown if we did not have those new technologies. And I think we're heading the same way again now. We're in lockdown again. That's why my lovely haircut and my COVID hairdo now. There's some comments from people online. Brendan Scully. So Brendan is one of the consultants on Northern Ireland. just drop me an email and I'll get you connected with Mags, with people from Endomag, because I'm sure that they will have some procurement argument for cost and how you get the mag seed versus wires. As you know, the way things are being dealt with in Northern Ireland is completely different than England, it's completely different than Scotland in terms of the HRG codes and things like that. So I'm sure that they can help you, Brendan. I'm sure you have my email, just drop me an email. Susan Hinglet also was one of the consultants in North of England, saying that they had no issues at all with stereo mag seeds. And I think there's lots of comments online. There's still about 50 questions on the question and answer section that we did not go through, but we'll try our best to see how things go, because it's nearly 15 to 7 and we really need to finish. I think we're trying to get a high definition copies of some of the presentations that we're allowed to share, and the presentations that we are allowed to share, it will be guided by the surgeons. If we're allowed to share, we'll use them on the iBreast book, mainly the talks separately. It will not be the full discussion. Any questions or any comments from anybody? Anything, Ash, you want to add?
I think it was a brilliant, concise and precise presentation. And thank you, the speakers, for your perspectives, your comments, your expertise, for sharing it with a wider platform, especially for those who are going to be converted, or total magnetic conversion, as we call it. Well, I like that title, by the way. It's great to see that these innovations are being driven more by the position that we're in, and how things like fast forward and MagSeed and MagTrace, and they've suddenly become things that we've adopted more out of necessity, but are good adaptations. I would think all of us would agree. And thank you all again for your time, giving up your time and your expertise and sharing all that learning with us.
May I just share one last thing before we finish? First of all, any comments, Omar?
No, thank you so much, Yazan. Great webinar and great information. And I would like to thank all the speakers, and I would like to thank you and thank Ash, and thank you all.
And before we go, can you see the screen, the new share? So yes. In 2 weeks' time, we have another webinar in collaboration with Senaturk, a great team from Turkey, led by Bahadir Gulgulu, who's has been a great colleague, helping in many aspects with delivering those online projects. The next webinar is about breast surgery is less more. So it's about critical thinking of low-value procedures in breast cancer surgery. We tend to complicate things. Many times we don't need to. We need to de-escalate things. And that's the idea from the next webinar. So we have Oresti Gentilini from Milan, who's going to talk about the escalation of sentinel node biopsy. So very much in keeping with the webinar today, we have Marjolein Schmidt from the Netherlands about, can we omit sentinel node biopsy after neoadjuvant treatments completely? So that would be a very interesting talk. And we have Maria João Cardoso from Portugal, who's going to talk about avoiding unnecessary oncoplastic breast surgery. We all finish training and we want to do more and bigger operations. And sometimes that's not what you want to do. And we have Philip Pootmans from Belgium and Michael Genant from Austria on the panelists, along with Bahadir from Turkey and my friend Omar. And I think Ash will be joining us, because Ash will be also in the Jaipur course running at the same time. And we will be hoping that Chris Holcomb, who's the president-elect for Association of Breast Surgery in the UK, will be joining us in that. So it's a free registration. You will find the details on the website, and we'll send you all the details also in the follow-up email. Also, I must mention that there's talks now with our colleagues from Italy, and I think Giuseppe was online today, so there might be some more webinars also with a team from Greta, which is a great team led by Maurizio Nava, Giuseppe Catanuto, and Nicola Rocco, and we're planning webinars on breast surgery, on the cosmetic breast surgery. And I think every breast surgeon, even if you don't do cosmetics, you need to know the principles of that, because I think one of the most important things that I've done when I did my fellowship is I stuck with the plastic surgeons and went and saw every augment and every reduction they've done. Though I don't do them privately, it's just that just changes the way of how you think on when you plan things. So that will be all on the follow-up email. I cannot thank you enough.
Yazan, do you have the Jaipur course to show off on your slideshare?
What is it, sorry?
You have the Jaipur course details on to put up on your slide.
I do not have them, but I will circulate them. That's not an issue at all. Just send me a link, and when I send the email, I will circulate that. If you have them on yours, we'll be more than happy. Just share your screen, because I think you send them to me on a WhatsApp. But it's an excellent course.
Afterwards, don't worry.
And Peter, it's been a pleasure knowing you from the past, and nearly was your registrar for a while. And thank you for the talk. Kate, has been a pleasure online, and Jill, cannot thank you enough for all the talks today. Andreas, you're part of the deal. Nearly every week we're getting you online now. Thank you again, everybody, and have a lovely evening or a lovely morning wherever you are. Thank you.
Thank you.
Yazan, lovely evening.
Thank you. Bye.